Welcome to the 2013 Sedation Peer-to-Peer Podcast. This educational activity is sponsored by the France Foundation and is supported by an educational grant from Hospira. Today's discussion is presented by Dr. Girard and Dr. Balas. Let's listen in.
So, Michelle, I was actually just at a SCCM committee meeting where we are working to provide practitioners with tools to implement the pain, agitation, and delirium guidelines in their ICUs. And actually, your work in Nebraska came up quite a bit as we talked about the ways that these approaches to managing pain, agitation, and delirium can be implemented in the real world in real ICUs, not just in the setting of a randomized controlled trial. So I'm really excited to get to talk to you some about it. And one of the things I wanted to ask you about is how have you made this happen on a daily basis, consistently, approaches that allow patients to be more wakeful in the ICU, which I personally think is really beneficial because it facilitates care in a different way. We're seeing more and more data about the benefits, for example, of mobility very early during critical illness, and it's really hard to get a patient mobile if they're not awake. And I think there are a lot of other benefits to wakefulness, but I'd love to hear you just describe some of the ways that you've made this happen.
Oh, well, that's really nice to hear that it's being discussed and that it's being acknowledged that, it occurred at the Nebraska Medical Center.
Yeah,
I would love to say that we are, at the point where we're 100% compliant, following all the new PAD guideline recommendations to the key. But I'd like to probably explain it more. It's still a work in progress. But the good news is, we implemented the ABCDE Bundle very quickly. We went from very little, no delirium monitoring or management strategies, and over the course of the year we're building. The good news is what we found is even if you make these incremental changes in the way you manage patients' sedation level or the way you treat or screen for delirium, you really do see improvement in patient outcomes. So I think one of the key points is, always aim for 100%. I'm a Scorpio, so I always try to over-challenge myself. But always aim for 100%, but recognize that even when you start these things, even little bitty changes really do in the end seem to help patients. So in case you're not familiar with what we did here is the method that we chose to use in terms of sedation lightening was actually using spontaneous awakening trials. Now, I don't know how you feel about the awakening trial part of it since we haven't talked too frequently. But in general, there's really two ways that the PAD guidelines recommend lightening sedation, and that's the targeted sedation, so targeting, using medications till you get to a certain target RASS score or sedation agitation score, or stopping the sedation daily. Do you have thoughts in either way? Do you feel strongly about either method?
I think that's a great question because I don't know if this was intended or not in the guidelines, but I think it's actually that we're potentially sending the wrong message if we tell people that they have to choose between the two. My personal approach in my practice, as well as what I recommend when I'm asked like this, is to do both. I think that we want our patients to be at all times as wakeful as they can be. The ideal patient is a patient who's alert and calm. We use the Richmond Agitation Sedation Scale, so that would be a RASS 0, but you could use any validated sedation scale. I think in the guidelines they recommend either the RASS or the Sedation Agitation Scale, the SAS. Mm-hmm. And my goal for my patients is always to be alert and calm. And I think the approach that we can take that's effective is both the targeted sedation, so tracking their level of sedation and then agreeing on a target as an ICU team, what's medically appropriate for that patient, which the vast majority of the time I think that we agree is an awake and alert patient. There's some exceptions. For example, the patient who's got very severe ARDS who you just can't oxygenate while they're awake, and you might, for a temporary period of time, have to sedate them to a deeper RASS level in order to facilitate oxygenation. But apart from some examples like that that are uncommon, I think that the patient ideally should be alert and calm. And going back to your question about daily sedation interruption, it's a misconception, in my opinion, that sedation interruption is only done in patients who are moderate to heavily sedated. As you
or
know,
even on continuous strips. I'm sorry to interrupt you, but even on continuous strips, people sometimes seem to equate that, stopping that sedation once a day is only for those people that are receiving continuous infusions, where really the intention is to have them have that period of awakening. So even if they're getting PRN medications, holding them until so that their brain could awaken a little bit and become more interactive with the environment. So I totally agree with you, and I think also the spontaneous awakening trials have gotten some bad rep, or the ABCDE Bundle, I hear, because it seems that people think that we're advocating for the use of continuous infusions of sedatives, when really that's not what the intention of the bundle is.
No, not at all. And I would say, I would even take what you said about the goal of the awakening trial when you said that it's to give them a period of wakefulness. I would take it even one step further, which is to say, yes, it's to give them a period of wakefulness, and it's to test their ability to maintain that period of wakefulness in a state that is calm and alert and comfortable. And if
Absolutely.
they can do that, then there's no reason that it would be a time-limited period of wakefulness. You would let them, you wouldn't restart the sedatives. So, as a pulmonologist, I very easily gravitate towards the analogy of the spontaneous breathing trial and the way that we manage patients' ventilator. When we put them on a spontaneous breathing trial, our goal is not just to give them a period of time where they're breathing without assistance. It's actually to test whether we can take them off the ventilator permanently. And in the same way, when we do a daily interruption of sedation, yes, we want to give them a period of wakefulness, but we also want to observe them during that period and see how they do. And because if they don't demonstrate signs of anxiety, agitation, pain, or other symptoms of distress that suggest they need to have sedation restarted, and as you said, restarting doesn't mean necessarily going back on a drip or starting a drip if they weren't on a drip before. It might just mean giving them another bolus of a sedating medication.
Or
and we can talk some about what that might be.
And managing their pain more appropriately.
Absolutely.
I think that's frequently overmissed. The misconception that, you have to hold pain medicines when you're doing these awakening trials and have the patient have pain, which is absolutely not the intention. We always want to treat the patient's pain.
Right, I agree. It's sometimes those stories of having a traumatic experience can be misinterpreted to be a reason to keep patients more heavily sedated. But the reality is that when you talk to the patients like you're describing, what they're saying is, I wanted to be awake. I wanted to know what was going on and to be able to understand and to communicate. I mean, the ability to communicate is so important. And time after time, we hear patients tell us that that one of the most frustrating things for them was the inability to communicate. And when they are comatose or delirious, even, then that's significantly impaired, if not impossible.
And it even impairs your ability to assess their pain. If they're so deeply sedated, I mean, they have the appearance of being comfortable, they have the appearance of being sleeping, but they may be having pain. And unless they're awake, alert, and interactive, there's no way that they can verbalize or express that to their nurse or doctor.
Right, I agree. And the first thing I always reach for when a patient is having symptoms of discomfort, even if it's not clear to me that it's necessarily pain. It may look more like agitation. I always first ask myself the question, are they receiving adequate pain medication? Because we know that patients in the ICU, study after study has shown us that patients in the ICU, and not just your surgical patients, but even your medical patients, are very likely to experience pain. I think 3 out of 4 patients roughly have pain as a major component of the symptoms they have in the ICU. So when I see a patient who's exhibiting signs of pain or even anxiety or agitation, I always ask myself first, are they receiving adequate pain control? For a variety of reasons, I tend to give fentanyl as an IV bolus and as my sort of drug of choice. I think you can take different approaches. I know others use morphine. It's going to be longer acting, which could be helpful. But and I found that many times, just giving that patient some fentanyl, there's no need for any other medication that might be sedating.
Agreed. I take the similar strategy, and I think my experience has been in the past, sometimes it's really important for institutions to look at their pain protocols, because nurses need to have the ability, I don't know how it is at Vanderbilt, but they need to have the ability to administer the amount of pain medications that the patient needs. Again, by that, maybe doing the targeted pain scores and things like that, as opposed to just, those Q2-hour or whatever they've been ordered in the past, boluses that oftentimes are inadequate to treat the patient's pain. And then because we've reached that Q2-hour, we've given all the pain medicine we could give, and the patient still has to have pain, still is having pain, but we can't give anything else. We can't reach the physician. Some people have a tendency to reach for the benzos or something that would hopefully at least calm them down, but is not going to be adequate enough to treat their pain. So the importance of empowering the nurses to have the ability to treat patients' pain, and realizing that it often may be doses that are more titrated to the patient's response as opposed to a Q2-hour or Q4-hour order.
Right. And my goal every single day when I'm taking care of an ICU patient is to treat their critical illness in a way that they can improve enough that they can leave the ICU. And if they're on a ventilator, then my goal is to assess them for the ability to breathe without assistance and get them off the ventilator. If they're on a sedating medication, whether by continuous infusion or intermittent boluses, my goal is to assess their ability to stop using those medications and to remain alert and calm without the sedatives. And if they can do that, then I don't give them the drugs again. So I'm always trying to stop those drugs. So that goes back to how targeted sedation and daily interruption are actually not mutually exclusive, but they're two approaches that can be used in concert. Because if I have a patient who's receiving sedatives, I'm always using targeted sedation, trying to maintain the lightest level of sedation that patient will tolerate. But in doing that, one of the ways that I am trying to get them to the lightest level of sedation is by stopping any of the sedatives that I'm giving them, whether by boluses or by infusions, at least once a day, as long as some safety criteria are met, and observing to see if they have to go back on the sedatives. A targeted sedation approach without a daily interruption would leave you asking the question, well, when do we just actually stop the medications? When do they no longer need them? And I think that the standard approach without daily interruption is to stop them once you get down to a very low level in terms of your dosing, whether that's the amount you're giving by a bolus or the amount that you're giving by infusion. But the nice thing about daily interruption, one of the nice things, is that we often assume that the patient will tolerate only small decrements or decreases in the doses of sedation that we're giving. And we fail to recognize that there are some patients that, yes, they needed some light sedation last night, but this morning they're ready to immediately go to no sedation. And
right.
So why take that test or that period of trial during awakening out of your armamentarium? To me, it seems like it makes the most sense to use both.
But Tim, don't you think one of the things that people struggle with is we are so deeply ingrained with the belief that people in the ICU need sedation, that it's unkind or not compassionate to have someone that's on the ventilator that's awake and alert. That's something that I seem to encounter when talking to clinicians, is that they really do believe that sedating patients is the right thing, the right, humane, compassionate thing to do. So I have my ways of how I approach that. What have you found to be effective to start changing that really deeply seated belief?
Well, I'm excited to hear your approaches. My general approach, when you're talking about being at the bedside in my ICU, and I'm talking to another physician or a nurse, or even perhaps a family member that has that opinion, well, my father's really, really sick. Don't you think that they would be better off if we kept them sedated? And I've just told them, well, today one of the things we're going to do is try to get them off sedation. When anyone asks me that question and I'm at the bedside, the approach that I generally take is to say, well, we have an approach that's been tried in thousands of patients, and it's been proven to be very safe, and it takes what they need as the direct determinant of whether or not we continue to give the sedating medications or not. So we're not going to just blindly assume either way. We're not going to blindly assume that they need these drugs because they have side effects and they have potential harm associated with them. But we're also not going to just blindly assume that they don't need the drugs. What we're going to do is we're going to do a test, and we're going to find out. And that test can be by decreasing the sedating medications if you're taking the approach of targeted sedation, or it can be by doing an interruption of those sedating medications. And I often remind other practitioners that I'm working with, or even family members, that just because you've turned off the continuous infusion, or just because you've held a intermittent bolus that may have been given on a Q4-hour schedule or some other schedule that patient had been getting prior to making your change, it doesn't mean that you're actually totally stopping the delivery of sedating medications to the brain, because the reality is that these drugs continue to float around in the bloodstream and continue to affect the brain long after the infusion pump is turned off or the bolus medications aren't being given. So there is some reassurance there, right? There's some reassurance. No, we're not making a dramatic change that will result in irreparable injury if the patient turns out to have needed the medication. What we're doing is we're turning off the drug. It's going to gradually leave their system, or we're not going to give the next bolus, and whatever is left from the last bolus is going to gradually leave their system. And we're going to observe the patient very carefully, as we do for any critically ill patient. And if they demonstrate signs of anxiety, agitation, pain, or other symptoms that suggest they need a sedating medication, we can always give them the drug at that time. But by assuming that they need the drug, we're actually very likely to be giving them more medication than they need. And I think that most practitioners in the ICU, most patients and family members in general, when they think about the potential downsides of giving someone a medication that they don't really need, they start to realize, okay, there are some problems with just working on these assumptions. And if they have more specific questions about, well, don't you think it would be better if they don't remember, if they wake up? I'm concerned that they'll be scared because they've got a tube in their throat, and then they're going to have that. I heard about the possibility of having anxiety after being so sick in the ICU. Don't you think it'd be better if they don't remember? At that point, I just have to defer to the research, because Anything else is just an assumption.
Right, but you and I live and breathe this. We've probably read every study that's ever been done about sedation, agitation, delirium. And one of the things that we found in our implementation study was really there is still a huge knowledge deficit as it relates to these things that we know to be true or that have been shown to be true in randomized control trials, with all the hazards of sedation. That doesn't seem to always be diffusing down to the bedside. Which is something that I'm always struck by, and is one of the key things that we found with our study is the amount of education that's needed regarding the new PAD guidelines or the ABCDE Bundle in general. There's a lot of education that needs to be done, and that education really, truly has to be interprofessional in nature, because it's just not one single profession that's influencing these sedation patterns, right? You have your pharmacists who are usually actively involved in developing protocols, approving what medications could be used in the ICU. You obviously have your physicians that are ordering and sometimes have their kind of tried and true medication that they like and that's what they use in residency and that's what they'll use till they die. And then obviously you have the nurses who are the direct administrators of the drug. So any kind of education, we found that we had to do, we did numerous educational efforts. So we did 8-hour ABCDE Bundle day, a full 8 hours related to a lot of the pain, agitation, and delirium guidelines, full 8 hours, very well attended by the nurses. We had one of the leading experts, Wes Ely, came out and talked at medical grand rounds. We did numerous surveys, focus groups, one-to-one teaching with the nurses, binders, the pocket cards that have the sedation, agitation instruments, and delirium instruments on. We did what I thought was a tremendous amount of education. And interestingly, there was still a lot of questions at the end of the study about, because these are really pretty strongly held beliefs. So I guess one of my suggestions would be when you're making your educational plan for implementing these PAD guidelines, one, make sure that all of the professions involved in the patient's care have the education, not just a single discipline, because that would kind of be futile because, again, a lot of different providers are involved in the care, but also don't underestimate the amount of education that's going to be needed to be provided.
Yeah, absolutely. And then there's also the issue or the profound influence that personal experience has.
Absolutely.
And I think that all of the education and the knowledge that comes from that education that you're describing forms a very important foundation upon which other things can be built. And one of those things is personal experience. And I just can't understate the power, and I think you've probably had the same experience of having being at the bedside and seeing a patient that in the past, or maybe even at that moment, you would normally assume needs moderate to heavy sedation, and then because of the education that you received, because of the recent research, because of the encouragement of agents for change in your institution, in your hospital, for all these reasons, you try it and you actually reduce the amount of sedation, or you turn off the sedation and you let that patient wake up, and lo and behold, everything you've been told recently turns out to be true. The patient really does well. Yeah. And I can't understate how many times in the last 5 years I've seen a colleague, whether that's a nurse or a physician or another one of the practitioners in our ICU, turn from having the opinion of, well, this patient was really going to have heavy sedation because look at how much PEEP they're getting, or remember how they had that period of agitation last night. They turn from that attitude to being a strong proponent for what we're talking about, keeping patients wakeful, alert, and calm for as much of their critical illness as they will tolerate. And they become passionate about that, and it's because they've definitely had all of the education, and they learned about all of the research and the better outcomes that study after study after study shows that patients have when they're kept awake rather than heavily sedated or even moderately sedated. They know about that, and then they see it become reality right before their eyes.
Yeah.
And they have in their minds these patients that they had assumptions about, and then their assumptions ended up being not true, that the patient actually did quite well on little or no sedation, despite being on high ventilatory settings with an endotracheal tube in. And not only did they tolerate having the drugs turned off, but then they were able to participate in the care plan. They were able to communicate with the nurses and with the doctors and with their family members, and they were able to even do physical therapy and all of these things that previously hadn't been believed possible for someone that sick. They actually see it happen. And so I think the combination of the foundation of the education upon which these personal experiences can be built is key to making this kind of thing happen.
I agree. It's actually interesting that you brought that up, not to get too theoretical, but really that empirical evidence, so the randomized control trial, that's just one way of knowing. That personal experience and the ability to empathize with the patient and their situation, particularly for nurses. I mean, this has been shown in research, but nurses sedate for multiple reasons. And a lot of it has to come down to them having that ability and those experiences and thinking that what they saw and remember. So I can't overemphasize the importance of having those little successes. Trying it with not thinking that you're going to do, starting slow and then increasing in progress, not thinking you're going to do this maybe immediately for every single patient, but maybe starting, if you have 5 intensive care units in your hospital, maybe it'd be best to start with 1 unit and focus on the sedation lightening and let those providers see the successes that come about. And we also found, doing this in everyday life, that the power of hearing the patient's experiences of being sedated is absolutely moving. We can speak about all the randomized control trials we want. When you hear an experience of a patient who experienced delirium or some of the side effects associated with sedation, when you hear what they perceive to be reality and the experience that they struggle with even years after being in the ICU, lots of recounts of a lot of post-traumatic stress disorder, but lots of account of remembering being restrained and people feeling as though they were being raped because of probably their perception of being tied down and maybe getting, our pericare done or whatever like that. When you hear it from a patient, that is a very moving experience as well.
This concludes the discussion. We would like to thank Dr. Girard and Dr. Balas for their contributions and continued support. Thank you for listening. To receive credit, please complete the evaluation form found on the website www.sedation-cme.org.